Okay, now we're going to look at the corticospinal tract in much, much more detail. Okay, kind of break it down like we did with the DCML and the STT tracts. So we have here, let's go ahead and, so this is just my midline. Okay, just kind of give us an idea for where we are. And thinking about what all these things are. What's the name of this thing that resides in between the thalami, part of the ventricular system? What's this one right here? That's my third ventricle. Good. Third ventricle. And then connecting the third ventricle. Here, this is the foramen of Monroe, connecting the third ventricle with these two other ventricles that are on the side. What are the name of these two ventricles? Those are my lateral ventricles. Okay, lateral ventricles. And then connecting the third ventricle with the fourth ventricle, there's this nice little, that's the cerebral aqueduct. Cerebral aqueduct coming through the midbrain. Cerebral aqueduct. Okay, and then hopefully everybody knows this guy, this pair of great big nuclei that are really important for sensory information. There's your thalami. Thalamus is one. Thalamus. Okay. We talked about, when we started the talk, thinking about influence, regions of the brain that influence movement. Talked about this when I labeled them purple, so I'll go ahead and keep them purple. But these guys are, yeah. So those are going to be your basal ganglia. Basal ganglia, important for initiation and amplitude of movement. Okay, in general, lots of different nuclei. So you have your caudate nucleus, globus pallidus internus, externus, and putamen. We'll worry about all of that stuff later. But for right now, consider this a collection of things. It's called basal ganglia. Yeah, I think we're set up. And consider up in the primary motor cortex, you have your upper motor neuron here residing, upper motor neuron cell body residing in the primary motor cortex, or S1. Okay, coming out of the cell body, you have your axon. It's going to come down ipsilaterally. It's going to travel, the axon travels through this little area between the ventricles and your basal ganglia and stays ipsilateral all the way down through the midbrain. Okay. And bless you. This is your corticospinal tract. Corticospinal tract, responsible for voluntary movement. Every muscle in your body. Okay. We also talked, when we talked about the STT and DCML, we talked about this important space here between your basal ganglia and your ventricles. Does anybody remember what that space is? It's where all the sensory and motor information travels through this space. You got it. That's your internal capsule. Okay, your internal capsule. Okay, so essentially upper motor neuron cell body resides in M1, or primary motor cortex sends out an axon. That becomes the corticospinal tract, which travels down the corticospinal tract. So common origin cortex going down to the spinal cord, corticospinal. Axons travel through the area of the internal capsule, stay ipsilateral all the way down through the midbrain. Okay, that's the first part. The next part moving on to CST is corticospinal tract. CST decussation. Come on, decussate medulla. Okay, basic labeling. Which part of the brainstem is this up top? Midbrain. A nice marker in the midbrain, part of the ventricular system. Cerebral aqueduct. Okay, midbrain, another, what's this marker here? It's a cranial nerve in the midbrain? Cranial nerve number 3. Oculomotor. Okay, middle portion of the brain stem, what's that called? Pons. And then this down here is your medulla. Medulla looks a little bit different today. I added a little bit of definition to it. And this is actually what you see when you look at the actual medulla on the brain stem when we pull them from the cadavers. Okay, there's a couple little bumps. That's what I'm trying to say. So here's the middle. So here's my middle. Okay. Then I have 2 bumps. I have an outer bump. I can see it over here. So that if these were 2 fingers, so that would be, I have 1 bump and then an outer bump here. The outer bump is known as the olive. That's your olive. And it's bilateral. There's olives on both sides. The olive is nothing more than the outermost bump, the most lateral bump on the medulla. And then does anyone know what the innermost bump is called? That's your pyramid. The pyramid. Okay, so what you have here is you have an olive, and you have a bigger bump that's a pyramid. Then you have the middle space, and then you have another pyramid, and then you have another olive on the other side. Okay, and the bottom is just the spinal cord. All right, where we were here, coming down, we're still on the right side over here. So here is the corticospinal tract coming down, comes down through the medulla, all the way down through the medulla, midbrain, through the pons, to the level of the medulla. Slide down? Yeah. So, corticospinal tract, coming from above. We just looked at it all the way down to the level of the midbrain. Well, it's here starting in the midbrain, coming all the way down through the midbrain, through the pons, to the level of the medulla. And then once it hits the area of the pyramids, hence the pyramidal tract, it decussates to the opposite side. So the corticospinal tract is going to decussate at the level of the medulla, specifically in the pyramids. Okay, and we talked before about this is called a pyramidal decussation. Okay. And you should know that approximately 90% of the axons are going to decussate at the level of the pyramids in the medulla. Only 90%. There's an extra 10%. But once those 90% decussate at the level of the pyramids, then they're just going to travel down. Now we're contralateral, below the level of the pyramids in the medulla, coming down through the spinal cord. Those that crossed over at the level of the medulla, as you're traveling through the spinal cord, this tract is the lateral corticospinal tract. Okay, we're up here before the decussation. This is just known as the corticospinal tract. Okay, so at the level of the medulla, you cross over. At the pyramidal decussation, approximately 90% of the axons cross over, and then traveling down the spinal cord becomes a lateral corticospinal tract. Okay, that extra 10% of axons that didn't cross over, did not decussate, they're just going to come down. Just keep staying ipsilaterally, coming down. Okay, this is an extra 10%. So these are the 10% that didn't decussate. Okay, the 10% that didn't decussate, that's going to be your anterior corticospinal tract. And if you remember the spinal tract cross sections, the spinal cord cross sections we did, you have the lateral corticospinal and the anterior. We're going to look at that here in a little minute, but this is where those axons come from. Okay, so corticospinal tract comes down, stays ipsilateral up until the level of the medulla, the level of pyramids. Pyramidal decussation, 90% of the axons cross over, come down and form the lateral corticospinal tract, and that's what you're going to see when you look at the spinal cord cross sections. 10% that don't decussate are going to travel in the anterior corticospinal tract. We'll see that again here in a minute. Questions? Yes, Pat? I don't know the answer to that question. I'm not sure anybody does. The anterior corticospinal tract, the one thing I do know is they innervate mostly axial muscles. Okay? But they will decussate, but you just haven't seen it yet. Okay, so they're at a different level. Okay? But, you know, everybody on the corticospinal tract will eventually decussate, and that's important for clinical presentation. Right? Everything you see is going to be contralateral. But they haven't decussated at the level of the medulla. Why? I don't really know. Yes, Alex?
Are those two names for which columns they travel through?
Yep. Absolutely. We're going to see that in a minute. Any other questions? Okay. So we're good. This is the CST, corticospinal tract decussation, 90% decussate in the medulla. Now moving on to the upper motor neuron meets the lower motor neuron in the ventral horn. Okay, let's go ahead and look at this. We have, so coming down. This is just the spinal cord coming down. Okay. You can draw in, and then so this is our dorsal great horn. And then here's our ventral great horn, labeled on this side. Okay, and we also had lateral corticospinal tract. Got to put that in here. So your lateral corticospinal tract is going to be here just anterior to my dorsal great horn. And it's going to be on both sides. And then my anterior corticospinal tract is going to be here in the anterior column. So lateral corticospinal tracts in the lateral column, anterior corticospinal tracts in the anterior column. So this is going to be your lateral corticospinal tract, and that's on both sides. And then this one's going to be your anterior corticospinal tract. Everybody see where we are? Okay, so all it is just labeling some things here. So we know that this is a dorsal root ganglia. Here's your ventral root. Here's your dorsal great horn. Second order neurons for SCT. right? Ventral great horn. And your ventral great horn, what's the ventral great horn house? Does anybody remember? Neuronal cell bodies for your alpha motor neuron. Okay, and I'm going to put in 4 specific ones in here. I'm going to put 2 rows of alpha motor neurons here. Okay, so there's going to be a top row and then a bottom row. Okay, these are just going to be neuronal cell bodies for the alpha motor neuron, or the neurons that are responsible for innervating muscles for voluntary movement. And why I'm putting in 2 is I have something here that's called a somatotopic relationship. Does anyone know what that means, somatotopic relationship? They're positioned according to the body. It kind of gets interesting. So if you think about upper extremity, I think it's easier. So you know Popeye sits here like this, right? So I'm here. So things that are more medial are going to be more proximal. Things that are more distal are going to be more lateral. Okay? So these alpha motor neurons are going to be more proximal musculature, and these are going to be more distal musculature, and I'll label them in a minute. The other thing, sometimes it can get confusing when you think about the legs. The same relationship exists for the legs, but I think it's easier to see for upper extremity. Because if I'm holding my arms in this position, the top row represents flexors. All my flexor musculature is going to be on the top row. And then the bottom row is all extensor musculature. Okay, so let's go ahead and look at that. Let's say that this is flexor musculature, so I'm just going to say biceps. Okay, and this is going to be a more distal flexor, so let's just say finger flexors. Okay, and then on the bottom row, we're going to have a more proximal extensor, so that's going to be triceps. And then further, you can even say finger extensors. Okay, does everybody see that? So this is called a somatotopic relationship. So cell bodies in the ventral great horn that have a somatotopic relationship organization, whatever you want to say. So flexors on top and proximal is more medial. Okay, so all those neurons have a somatotopic relationship. Questions about that? Thinking about it, Dean?
Are the flexors always on top?
The flexors are always on top, even for your lower extremities. But so if I think about my lower extremities, if I have my leg up like this, okay, my knees, my hamstrings are knee flexors, but they're also hip extensors. And my hip extensors are on the top, so I don't think you can see it as well as if you do this. Right? Does that help? So I always don't just think about the role of the muscles. And if you want to visualize something, visualize upper extremity. I think it's easier. Other questions? Same relationship exists with lower extremity. Yes?
What do you mean by like proximal and medial?
So as medial in relationship to the position in the spinal cord, the more medial here is going to be your proximal musculature. The more distal is going to be the more lateral is going to be distal musculature. So those are alpha motor neurons that are specific for innervating those things. Any other questions? Does it make sense with the somatotopic relationship? And that's kind of an important point. Okay, now that we set everything up, we can go back and I think we, 90, yes, go Trinity, no, please.
So what are the little green parts called again?
Those are neuronal cell bodies. They're the neuronal cell bodies of the alpha motor neurons. We're going to label that here in a minute. We'll get there, but good question. I haven't gotten there. I'm trying to set this up. Anybody else? Do I see where we are? All right. Now, 90%. Here's 90%. Remember this 90% of axons that had already crossed over. They're on the other side. They're going to travel through this lateral corticospinal tract. Okay? And all I'm doing is I'm just coming down the spinal cord. But as they travel, they're going to travel as a group of myelinated axons in this position here. That position is the lateral corticospinal tract. So 90% are lateral corticospinal. Okay? So as they're traveling down the spinal cord, they're coming down in this space. Okay? And let's just say that these axons are going to be specific for finger flexors. Okay? So they're going to come out of the lateral corticospinal tract, come over to the finger flexor lower motor neuron cell body. Okay? They're going to synapse there and then send out an axon, and their axons are coming out here through the ventral root. And those are going to innervate finger flexors. Does everybody see that? All right, it could be any. I mean, I could have this alpha lateral corticospinal tract could have been anything. It could have gone to finger flexors, bicep, could have gone anywhere. But kind of the idea is if it goes here, it's going to be more distal and it's going to be a flexor muscle. Okay. Now these things here, all these neuronal cell bodies are going to have axons that come out. They're all going to come out through the ventral root. Okay. And those axons are going to be specific for whatever they innervate. Okay. These neurons here, these are the neuronal cell bodies for your, you can think about it as lower motor neuron, or another word you might hear is alpha motor neuron. Okay, so lower motor neuron, so those are the lower motor neuron cell bodies reside in the ventral gray horn in the spinal cord. Okay, and they come out. Does anybody know the disease process where a virus destroyed the alpha motor neurons in the ventral gray horn? Not very many cases around anymore. A couple years ago, there was one case in New York that popped up. It had most people get vaccinated for it. Yep, polio. That's actually how our profession started, really. That's where we as a profession started by learning to work with patients post-polio in the early 1900s. Does anybody know anybody with polio or know anyone? Not a whole lot of people now because of the age, but since the Salk vaccine, not a whole lot of people with polio. Okay, but that's what happened. The virus came in and destroys these cells, and they present like lower motor neuron lesions. We're going to talk about what that means here in a minute. Okay, now, the next point. This is 90% travel through the lateral corticospinal tract. They had this other 10% here. These axons were traveling down, and these are traveling through the anterior corticospinal tract. Okay, the anterior corticospinal tract. And with the anterior corticospinal tract, we don't cross over till you get to the level, the spinal level that you're in. Then when you hit that spinal level, you come out and you decussate. And again, they can go on. The anterior corticospinal tract is more apt to be specific for axiomusculature, but just to show you what happens, it comes out, crosses over, and synapses with the lower motor neuron contralaterally. So all corticospinal tract presents contralaterally, which is what you'd expect. Questions? Yes, Pat?
You said decusates at the spine of the...
It's decusates at the spinal level that it's going to synapse with the alpha motor neuron. Decusates at that spinal level.
Is there a special name for this?
No, there's not. Good question. No, there is no special name for that decusation. They just decided to come across and innervate. Other questions? Okay, and that's it. 90% come down, somatotopic relationship. Other 10% anterior corticospinal top tract, decusate at the level of the spinal that they reach. Moving on.
Sorry, one more question.
That's fine.
So since it's contralaterally and this we drew it on the right side, this is all going to affect the left side, or like your left flexor.
Yeah. So I don't know if I understand your question, but let's go back and just make sure that I understand your question. So when we started at the level of the brain,
Yeah.
okay, it was on this side,
Yes.
and let's go ahead and so let's.
Okay, because it's already transferred.
So this would be the left side, and this would be the right side. So coming down the left side at the area of the left M1, coming down 90% decusate, but this stays on the left side. Okay. Now when you come down and look over here, same thing. This is going to be my left side, and this is going to be my right side. So at the level of M1, if the lesion's up here in M1 on the right side, everything's going to present on the right side. Sorry, did I say that right? If the lesion's in the primary motor cortex, all going to present contralaterally. All. Yeah, Tyler?
Does the lateral corticus spinal, does that innervate all the neurons of the body and help the integrate?
Yes. The lateral cortical spinal as well as the anterior cortical spinal as well. Both of them will innervate. Okay.
Is there a difference, or they just have every neuronal cell body has one for each?
Every neuronal cell body has not only one from each, but if it's appropriate, they might also have rubrospinal, or they might also have vesiculospinal or vestibulospinal hooked up to them. So that if you lose the corticospinal influence, then the others. So I'm trying to make it really simple, but really there's like millions of neurons and axons coming down. Okay? Okay, other questions? Does that make sense? Try to make it as easy as possible. All right. And as an overview, did you have a question? You said you're pretty sure. Oh,
You just said that they both synapse with all of the neuron cell bodies. Both those.
Yeah. So the anterior corticospinal tract is going to predominantly go with axial musculature, and the lateral corticospinal tract will go with anything. Okay. Moving on. So just a quick overview. Looking at question, Sam?
Sorry.
That's fine.
I think is there a lateral cortical spinal tract on each side?
On each side, yes. Lateral corticospinal tract on each side. So if I have the primary motor cortex on my right side, come down at the level of medulla, you cross over, and then you come down 90%. Also one on my left side, coming straight down, the level of medulla, cross over, and come all the way down. Does that make sense? So I'm just trying to make it easy to see. But other questions? Is it getting clear? Are you seeing what's happening? Okay. Question? No. So, we started out talking about this medulla piece that I had left off before. And I talked about what's the outermost piece called on the medulla? That's your olive. Anybody like martinis? You like martinis? I'm impressed. They're strong. Okay, that's your olive. And then what's the middle one? What's most medial? That's your pyramid. That's why the pyramidal tract comes from. Okay, and staying on the same side. So since Sam asked that question, let's start on the other side this time. What happens is, this is just a big old overview. Here's my upper motor neuron. We're going to talk about that in a minute. This is my upper motor neuron cell body, residing here in M1, primary motor cortex. Comes all the way down, stays ipsilateral to the level of The medulla, specifically the pyramids in the medulla. 90%, and that's all we're going to look at here, is going to cross over the level of the pyramids, go contralateral, and then slide on down. 90% is going to be in the air, going to come down the spinal cord in the lateral corticospinal tract. Okay. Then once you get here, it's going to synapse in the ventral great horn. It's going to synapse on an alpha motor neuron that comes out and resides in the ventral great horn of the spinal cord. It's going to send out its axon through the ventral root, and it's going to innervate skeletal muscles. Okay? And this is your lower motor neuron. Difference between an upper motor neuron and a lower motor neuron. Questions? So everybody see that? So just a big overview, just taking the whole thing. We broke it down into little bits and pieces, and this is the whole thing, looking at it. It's just that simple. Okay, so a lesion up here at the level of the M1, primary motor cortex, is going to present ipsilateral or contralateral for motor loss. Contralateral, good. How about a lesion here in the spinal cord? All right. Okay. Well, hold that thought. Keep thinking about it. We're gonna talk about this as we come. We'll get to some clinical correlations, and I'd like to have you guys think about it a little bit more. Okie dokie. Let's do now. At the very beginning of the presentation, we talked about these other descending tracts that are coming out of the brainstem. Okay, let's look at those again in a little bit more detail. And let's use, let's use here. Let's talk about, so if I've got, it's going to be hard to use upper extremity and lower extremity at the same time, but that's okay. Sure. So I'm just drawing some alpha motor neurons here. Okay, those are my alpha motor neurons. And again, they have the somatotopic relationship. And we talked previously, we'll draw it in here again, looking at what all exists, just kind of a review. So you have, here's your lateral corticospinal tract, right? Lateral corticospinal tracts on both sides, because it's going to handle both motor information coming down from the right and left half of the brain. And decussate at the level of the medulla. Okay. I'll just draw a few more. Okay. Underneath the lateral corticospinal tract, or just anterior, ventral to the lateral corticospinal tract, there's going to be this tract right here. Does anybody remember what tract this is? Yeah, that's your cerebrospinal tract. Kind of gave it away. I used the right color, right? So the cerebrospinal tract. Okay, and then we talked about the anterior corticospinal tract being here in the anterior column. There's two other descending motor tracts that are present in the anterior column. I don't remember what colors I used way back when. Let's see. Okay, up top, there's going to be something here in the anterior column. Does anybody remember which one that is? Yeah, that's reticulospinal. And below it is going to be your vestibulospinal. Reticulospinal is on top because it begins with an R.
What color is your?
I tried to make it a green. Green, so, and I'll label it. So this is going to be up top. I have my reticulospinal tract. And underneath that, I have my, in orange, my vestibulospinal tract. These are all in the anterior column. So the anterior corticospinal, Reticulospinal, vestibulospinal. The only one who's in the lateral column here is going to be your rubrospinal tract. That's going to be paired up with your corticospinal tract, lateral corticospinal tract. So let's see where I am. So a little bit of review. This is what we talked about when we did the spinal cord overview. Any questions about this? And kind of the same thing. We're going to see the same thing happen. We have up here in the midbrain, there's a nucleus. And let's put, here's my midline, just for reference. Okay, up here at the level of the midbrain, there's this big old nucleus. Okay, that's going to be your red nucleus. The red nucleus immediately sends an axon out that decussates the level of the midbrain, and it's going to travel all the way down contralaterally through the rubrospinal tract here. Okay, and then we talked about the rubrospinal tract is going to come in, and we talked about it being specific for elbow flexors in humans. So that's your rubrospinal tract. Remember, there's one on both sides. Let's just say elbow flexion. Okay, there's your elbow flexion. So rubrospinal tract is here, right there. And you're going to see if we made cross sections all the way through the brainstem, you'd also see something labeled the rubro, which we will see, rubrospinal tract. Okay, travels down through the spinal cord in the rubrospinal tract, comes out at the appropriate level, and rubrospinal, mostly elbow flexion in humans. Okay, and then right at the level of these descending in the brainstem, this is the only one that decussates. Okay, it's not under conscious control, but the red nucleus, the rubrospinal tract, is the only one that decussates. The others stay ipsilateral. So here we have, bless you, there's my vestibular nucleus at the caudal pons. Okay, your vestibular nucleus sends out axons that stay ipsilateral. They travel through the vestibulospinal tract. When they get to the appropriate level, they're going to come out and innervate synapse with extensors. So I put them on the bottom. Okay. You're going to come out and synapse with extensor musculature. Okay, so this lower motor neuron here, remember, if you're on the bottom, you're an extensor. Going to travel out through the ventral root, and that's extensor musculature. Okay, and that's going to be your vestibulospinal tract. We also have, I use green, yeah, okay. Sort of green. We had this diffuse set of nuclei here in the medulla. That's going to be your reticular formation. Okay. Your reticular formation sends out axons, travel through the reticulospinal tract ipsilaterally, and they're going to come out and synapse with alpha motor neurons that are specific for extensor muscles. Questions? Yes, Jared?
So in this example, the reticular formation is sending the information deformation to the more distal extension? Is that typically what happens?
Reticular formation is, so think about in general extensors. And I didn't want to confuse you by saying which extensors, because I'm at the level of the biceps on one side and I'd be at the level of lower extremity on the other side, if you want to think about it that way. So it's really all extensors, yeah, any extensor. Typically, reticular spinal is vestibular spinal. Think postural extensors. You want to be upright against gravity if you're awake or if you're standing up. Do you have a question or just stretch it?
I'm all out of questions.
You're all out of questions? Okay. I'll go ahead, Pat.
Which one did you say, postural?
Both reticular spinal and vestibular spinal. Predominantly, so both are postural extensors. Okay, so you're going to see it in the back as well as the lower extremities mostly. Other questions? If you know extensors, you're good. If you're awake, you want to be upright against gravity, and if you're standing or sitting up, you want to have good postural extension. Question? No. Okay. Now, I've been saying these words, upper motor neuron versus lower motor neuron, and why that's so important is you need to know, as a PT, I guarantee you it will be on the boards, the difference between an upper motor neuron presentation and a lower motor neuron presentation. Plus, we will spend the first half of a year, or half a semester, next year on the difference between these two. So let's get it now. We'll be good. You do, this is going to be upper motor neuron, okay, upper motor neuron, cortical region, central sulcus, midbrain, pons medulla. Here's my cross-section of the spinal cord. And we've talked about the fact that my lateral corticospinal tract, let's just put one here and here. The majority are going to come down lateral corticospinal tract. And I also have my lower motor neuron cell bodies are going to reside in the ventral great horn. Okay, there you go. Okay, so all I did was label, here's my lateral corticospinal tract. And here is my lower motor neuron cell body. Okay, we've been drawing upper motor neurons, so the upper motor neuron, as you know, is going to shift up here now. It's going to be in the frontal lobe, precentral gyrus, M1, primary motor cortex. We're not going to see the decussation, the most important part. If you're here, here's your upper motor neuron cell body, sends out an axon, it travels here through the lateral corticospinal tract, going to hook up with the lower motor neuron cell body in the ventral great horn. If you have a lesion anywhere along this upper motor neuron, along this axon, could be here, anywhere along there, okay, these would be lesions. Something bad happened to it. Okay, it is going to present as an upper motor neuron problem. There are certain symptoms, signs and symptoms that you need to associate with an upper motor neuron. Okay, so if there's an immediate, at the very beginning, if you have an upper motor neuron cell lesion, you can have a stroke. You can have a stroke that's affected anywhere from here all the way down to here, okay, until you get to the lower motor neuron cell body. There's going to be a beginning to the lesion. So let's say spinal cord injury, stroke. At the very beginning, patient's going to present with paresis or paralysis. Okay, does anybody know the difference between paresis and paralysis? Paresis is weakness. Paralysis is gone. You can't move it anymore. Paralysis is absence of anything. Paresis is just a weakness. Okay, in the beginning you're going to have paresis or weakness. You're going to have what's called hypo, H-Y-P-O, tonia. That means decreased muscle tone. Decreased muscle tone, so immediately after the injury, patient post-stroke or spinal cord, what happens is the central nervous system goes into shock. Everything shuts down. Hypotonia, absence of muscle tone. You can also have hypo or areflexia. Hypo or areflexia. That means decreased reflexes or no reflexes at all, absence of reflexes. So, immediately after upper motor neuron injury, you get hypotonia, decreased muscle tone, you get decreased or absence of reflexes, and you also get weakness, paralysis or weakness. That may progress to later. Patients still might have paresis and paralysis, but the hypotonia may become hypertonia. And then the hypo or areflexia becomes hyperreflexia. Okay, so what that means is immediately post-injury, you have one presentation, and later, patient might present. By later, I'm thinking about 2 weeks later, they may present with hypertonia, increased muscle tone, or hyperreflexia, or like increased reflex response. That's hyperreflexia. So if you see hypertonia or hyperreflexia, what are you thinking? Is it an upper motor neuron or a lower motor neuron? Upper motor neuron lesion. What causes it? So it's the spinal shock. Yeah, and also not everyone with an upper motor neuron lesion will have hypertonia and hyperreflexia. Okay, that just it's patient dependent. Okay, nobody really knows what causes those things yet. Other questions? The spinal shock shuts it down, but then it might progress. Okay, and then your lower motor neuron is here. Okay, so that's just right there. That's your upper motor neuron. And I like to just put real quick the lower motor neuron presentation. So we already labeled everything and looked at the upper motor neuron portion. So you start here, it's your upper motor neuron, travel down through the cortex, through the brainstem. Okay. Okay, travel through your lateral cortical spinal tract. I'm going to synapse. This is your upper motor neuron piece. Okay, this guy down here, your neuronal cell body, is your lower motor neuron. Okay, this is your lower motor neuron. Okay, we talked about the lower motor neuron cell body residing in the ventral great horn and the spinal cord. It's also known as the alpha motor neuron. It's the one that's responsible for innervating directly your muscles for voluntary movement. Now, if a patient presents with a lower motor neuron lesion, so upper motor neuron lesion could be stroke, multiple sclerosis, spinal cord injury, anything that has to do with an injury inside the CNS. Anything here, whether it's here or anywhere along here, is a lower motor neuron injury. Think nerve root injury, something we covered the other day. Carpal tunnel syndrome, nerve issue, right? Any kind of nerve issue, that's a lower motor neuron issue. Patient is going to only present one way. There's no change. It's paresis or paralysis. Hypotonia. Okay, something called fasciculations. Fasciculations are like a quivering muscle. We'll see pictures of them when we get there. They're also going to present with atrophy. Atrophy is just muscle wasting. And hypo or areflexia. So that means decreased or absent reflexes. Okay, that is very specific for a lower motor neuron injury. So if you see a clinical presentation where the patient presents with atrophy or fasciculations, you're thinking lower motor neuron, because those don't correlate with upper motor neuron. Upper motor neuron, you're thinking hypertonia, hyperreflexia. Lower motor neuron is hypo everything. Okay? Questions? This is something we'll get to. We have just one more thing to do. We can easily do that next time. So on Wednesday, again, prepare for your group cases. Okay? We'll do those during class time. And I will talk about the reflexes. Just one last little thing to do, but we're not going to do that now. Okay? We're done. Okay. Thank you. Question?